Welcome back in the part 2 video of TB preventive therapy. In this video, in discussion, we will discuss about preventive treatment in the DR-TB context. Okay, so let's start. Cases of MDR-TB or RR-TB with fluoroquinolone sensitive, H-resistant cases with R-sensitive bacteriology confirmed pulmonary DR-TB patient. So for these patients, contact or family members will be provided preventive treatment. How we will do it? We will first counsel and screen the contact, and if they are symptomatic, then we have to obviously rule out for the active tuberculosis, and if they are not symptomatic, then we will look for the age of the patient. If they are more than 5 years of age, then we will do a testing for TB infection that we do by using TST test, that is Montoux test or IGRA test. If that is positive, then we will do a chest X-ray. If chest X-ray is abnormal, we have to investigate for TB in that case. But if chest X-ray is normal or chest X-ray is not available, in that situation we will plan this patient for TPT, that is tuberculosis preventive therapy. And if TPT is not contraindicated, we will initiate this patient for TPT, that is preventive therapy. And if TPT is contraindicated, then we will defer this patient for TPT, obviously, for the reason. But all these patients have a follow-up for active TB as necessary, even the patient who have completed preventive therapy. So in that situation, we will follow up the patient. Another situation is if the household contacts are more than 5 years and they have a TST or IGRA test negative, in that patient we will have a regular follow-up for any symptomatic stage. But if the patient is having less than 5 years of age, if the household contacts are having less than 5 years of age, in those cases, without doing TST and IGRA, we will straight away provide them TPT, that is preventive therapy, if that is not contraindicated. Fine. And obviously, if the patient is symptomatic, if the household contacts of the case are symptomatic, then we will investigate for TB, and if that is a drug sensitive TB they have, they will be treated as a drug sensitive TB, and if they turn out to be a drug resistant cases, then they will be treated as a drug resistant TB cases as per current guideline that we are following. Alright. So how to approach this patient? So once a DR-TB patient has been identified, all household contacts are counseled, screened and evaluated to rule out active TB among them for those all contacts. Okay. And what we will do? We will do a NAT test, that is nucleic acid amplification test, among the contact with the symptom of abnormal chest X-ray to diagnose active TB. So we will offer NAT test for the contacts of the case if they are symptomatic or they have an abnormal chest X-ray. Abnormal chest X-ray means they have any shadows, they have any opacity on the chest X-ray, to rule out active TB among those. So if you do a NAT test, this result will come out to be either MTB detected, Mycobacterium tuberculosis detected, and rifampicin resistance is not detected. So then we will treat this patient as a drug sensitive TB. And if MTB is detected and rifampicin resistance is detected among the contacts, then we will manage this patient as per DR-TB guidelines under PMDT. But what if we do a NAT test among the contacts and if MTB is not detected? So, and we will screen out, we will divide those contacts based on their age. One is household contact HHC more than 5 years and those who are having less than 5 years. So in less than 5 years, we will assess them for preventive therapy and we will offer TPT regime as appropriate based on DST pattern of the index patient. We will just discuss these things just in a few minutes. So if the household context is more than 5 years, then we will do a TB infection test in the form of Montoux test or a IGRA, and we will do a chest X-ray. But if TB test is positive or unavailable or chest X-ray is normal, or if that is also unavailable, so in that situation we will offer TPT regime as appropriately based on DST pattern of the index patient. So what does this mean? Appropriate based on DST pattern means if the MDR patient, we will always, as per our guideline, in the MDR patient we send the smear for the first line and second line LPA for this patient, and if we have to know the sensitivity pattern, for example, if the MDR patient is sensitive to fluoroquinolone, then we will offer TPT as per the sensitivity pattern. If INH monoresistant cases, if that is sensitive for rifampicin, then we will plan them TPT as per their sensitivity pattern. Okay, and after that we will have a follow for reactive TB as necessary, even for the patient who have completed preventive treatment irrespective of their TPT offer. We have to follow all these patients for any development of the symptoms later. What are the regime? What are the TPT regime for the context of DR-TB patient? So TPT regime for context of DR-TB index patient is, there is two cases are there. One is MDR-TB with fluoroquinolone sensitive status. In those contexts, we will use 6 months of levofloxacin daily. And in cases we are having INH monoresistant cases but rifampicin sensitive patient, in that situation, in context of such patient, we will give them 4 months of rifampicin daily regime. So this is the regime for context for the DR-TB patient, and these are the weight bands and the according to the dosing of the drugs. So if 6 months of daily levofloxacin is given for the context of R resistant but fluoroquinolone sensitive patient, so if age is more than 14 years or by body weight less than 45 kg, 750 milligram per day, so that this is the dose as per the weight band. So there are 5 to 9 kg weight band, 10 to 15, 16 to 23. So as per weight band, we will give them therapy. Now 4 months of rifampicin 4R for the context of H resistant and R sensitive patient. For that patient, if age is less than 10 years or older, the dose is 10 milligram per kg per day. But if the age is less than 10 years, then the dose is 50 milligram per kg per day. And this is very important for us to consider. If the patient is receiving levofloxacin, then we should always look for the joint abnormality, that because we know that levofloxacin or fluoroquinolones have a side effect on their joint development. So we have to look for the joint abnormality in such situations. This is all for to understand the TB preventive therapy in the DR-TB context, and you can read this full guideline available here in the description box. This is the link given. So see you on the next video. If the video is informative, like the video, comment, share and subscribe the channel for the further new updates.